Hi, welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor for JAMA Network Open. Today we've got a special guest and a special feature. We've got an author who's local of our first paper, Dr. Katie Suda.
Hi everyone, my name is Katie Suda and I'm an associate professor at the University of Illinois at Chicago College of Pharmacy.
Great. So we're going to be talking about your paper today, The Comparison of Opioid Prescribing by Dentists in the United States and England by Dr. Suda and colleagues. And here you did a comparison, as the title says, between how dentists prescribe opioids here and in the UK. So tell us, why did you look into this question?
So in the United States, dentists prescribe about 10% of all opioids, second to family practitioners. And this makes sense that dentists prescribe analgesics because dentists treat a lot of pain. I'm sure we've all had the experience of having a terrible toothache and needing care from a dentist.
Yep, absolutely. Yeah, so tell us, what'd you look at and what'd you find?
So we used two population-level data sets. In the United States, we used a data set from IQVIA, which is called LRX, and it has 85% of all prescriptions dispensed from outpatient healthcare settings. And in England, we used data from the National Healthcare Service, which has all prescriptions adjudicated through the National Healthcare Service.
Yeah, I mean, one of the benefits in England of having a big centralized, essentially socialized medical system is that it's all going through basically one clearinghouse. It's one system. You can get really good data, which is nice.
Exactly.
Yeah, so what'd you find?
So we found that the proportion of all medications prescribed by dentists that were opioids in the U.S. was 37 times greater than in the UK and England.
Wow, that's amazing. And if we look at Table 1, what I found most astounding is that if you look at the population-based opioid prescribing rate, which is a mouthful, I'm sorry, in the US, it was about 35 prescriptions per 1,000 versus in the UK, where it was 0.5 prescriptions per 1,000 for opioids.
Right. Both the population-based prescribing rate and the provider-based prescribing rate was significantly greater in the U.S. when compared to England. We found that about 22% of all prescriptions prescribed by U.S. dentists were for opioids, where only 0.6% of all medications prescribed by English dentists were for opioids.
Right, and the prescriptions per dentist were a lot higher here as well, about 58 per dentist in the U.S. versus 1.2 per dentist in the U.K., which is just a huge, huge difference.
Yes, it is a large number.
Right, so what do you think factors into those differences?
So there's a different model in England. First of all, dental care is part of the public benefit. However, we see that there's similar oral health as well as similar use of dentists, not only for adults and older persons, but also for children between the two countries. Also in England, dentists prescribe according to a medication formulary, and the only opioid available for dentists to prescribe is dihydrocodeine, which dihydrocodeine is available in the US, but it's rarely prescribed. It's a codeine derivative, essentially. In the UK, they also have national prescribing guidelines that are specific to the treatment of oral pain. And NSAIDs and acetaminophen, or paracetamol in the UK, is considered first line, and opioids are not recommended for routine prescribing for the treatment of oral pain.
Okay. Are they still covered by the NHS?
Dihydrocodeine is, if it's a prescription, it is covered by the NHS.
Okay, and I'm going to cheat and take a question from a Twitter user who was talking about this a couple days ago. But in the UK, codeine's over the counter. I had some experience with that when I did a semester in Australia in undergrad. So how does that factor in here?
There are some low-dose codeine-containing products available over the counter in the UK and in other countries as well. Of course, that's not the case in the US. Those are primarily low-potency opioids, low-potency codeine-containing products, as well as these are considered pharmacist-only medications, so they're kept behind the counter.
Okay.
Pharmacists in the UK then screen the patients for appropriateness of the medication, as well if it's an appropriate indication, or if a different analgesic should be prescribed.
Okay, interesting.
And usually these are prescribed in very small duration, maybe a dose or 3 doses, or a short supply. We're not as concerned about the data on OTC codeine-containing products because those OTC products are not covered under the NHS, so patients would have to pay totally out of pocket for those medications. In addition, dentists would prescribe an opioid prescribed dihydrocodeine if they feel it's indicated. Based on my dental colleagues' knowledge, they would not recommend a patient to pick it up as an over-the-counter product. But even if it does triple the number of prescriptions that are opioids prescribed by dentists, there's still a large gap between the numbers.
Yeah, absolutely. And one of the other things that stood out to me that was interesting in this paper is looking at the figure, just what the different types of opioids are prescribed. I've always kind of heard anecdotally that codeine works well for tooth pain. And it looks like codeine was only 20-something% of the prescriptions for opioids in the US by dentists.
Right, good point, Seth. So 80% of the opioids prescribed in the US by dentists were non-codeine products. And there's a lot of data, more and more coming out, that shows that non-opioid analgesics have equivalent or non-inferior or superior efficacy as compared to the opioids that are combined with acetaminophen.
Yeah, we've definitely seen some other studies, things looking at chronic pain, as well as specific types of acute pain like low back pain, where opioids are just less effective than we think they are, or markedly similar to other alternatives. And it's pretty miserable. I've said here many, many times that we have this terrible problem where we have both the opioid epidemic as well as an oligoanagesia problem. And I think we really need are better options for managing pain. It's really tricky.
I agree. And we need to provide more resources for dentists and include them in the public health conversation of the opioid epidemic. Dentists don't have guidelines for the treatment of oral pain, and I think that these would also be useful for other provider types, such as emergency medicine providers who frequently see patients who have oral pain.
Mm-hmm. Yep, and I don't have the data offhand, but I'm sure there's room for improvement among me and my emergency medicine colleagues to, I'd say, more smartly prescribe analgesia for dental pain. So Mike is not absent. He's actually going to join us in the second half of the show. He's chiming in with a question. Are the reasons to think that there's procedural differences, for instance, different types of dental procedures being done with more or less pain between here and the UK that are accounting for some of these differences?
The only differences in practice between the two countries is that in the US, commercial dental insurance, routinely covers orthodontics for children and for some young adults. And also, commercial dental insurance also tends to cover implant procedures. However, in the UK, those procedures are not routinely covered. In Medicare and in Medicaid, those procedures are also not routinely covered unless it's medically necessary. Mm-hmm. But we do know that the healthcare systems are very different. About 20% of the entire US population does not have dental insurance. Mm-hmm. So there is an issue with access. However, again, multiple studies have shown that the oral health between the two countries are similar, as well as just because you have the benefit of going to the dentist and it being covered doesn't mean you actually use that benefit. And we see that again across all age groups, that use of dentists are similar between the two countries.
Okay. And that's interesting. I mean, even here, I've got pretty good dental coverage, and there's pretty decent out-of-pocket costs that go along with it, and it's always a big gamble, unfortunately.
Agree. Can I make one more
point,
please. Seth? One thing that we found was that U.S. dentists prescribed high-potency agents and long-acting agents, and about 1 out of every 10 opioids prescribed by U.S. dentists were for these agents. Oh. And of course, this is concerning because high-potency agents and long-acting agents are at high risk for substance misuse and drug diversion, where we did not see that UK dentists prescribe those medications.
Yeah, and I'll say I was pretty shocked when I read that. Even though the numbers aren't huge, it's still a non-trivial amount of prescriptions for long-acting pain meds. And while I guess at first my gut reaction is why are dentists doing this? I could probably imagine some situations where patients who have chronic dental pain and the dentist is the one who's managing their pain. So unfortunately, we want to get in a situation where we're not throwing out the baby with the bathwater, which leads to Mike's straight follow-up question is what kind of policy implications are there for both us and in the UK?
I think a first step is we can follow some things that have been done in England. So the English model is that there's more stringent prescribing rules for dentists where only dihydrocodone is available to be prescribed. So perhaps restricting the scope as well as duration of opioids prescribed by dentists could be a first step. But I think the other two larger, more important steps is we need to have national guidelines for U.S. dentists to aid them in their prescribing decisions of analgesia for oral pain. And then again, I think we need to include dentists in part of opioid prescribing interventions. Thus far, really only medical providers have been included as far as interventional efforts. There's some work currently happening, early stages, but we really don't know the effectiveness of implementation strategies specific for dentists.
Yeah, and not to be too cynical, but that it also lead to a whole raft of papers about poor compliance with guidelines and prescribing, like we see with physicians. And unfortunately, I think we're getting into another situation here where we value prescriber freedom, the prescriber, provider, and patient relationship, and the primacy of that. But the bottom line is, the more our bad behaviors or our, I'd say, misguided individual efforts continue, the more we're going to end up with the big heavy-handed force of the law forcing our hand into better situations, or different situations, I guess is a better way to describe it.
Right. We're doing qualitative research as part of this work as well. And one thing that we're continuously hearing is that dentists do not have resources to aid them, and they're actually asking for those resources. And one of my favorite quotes from our qualitative work is, when you only prescribe 5 things, it's great to know more about those 5 things. So I think for the most part, dentists are actually very receptive and really want the benefit of some additional guidelines or some kind of flow chart to aid them in prescribing.
Yep. I was finishing my residency in New York City when New York came out with the city of New York came out with some prescriber guidelines for acute pain prescribing, and there was, of course, a big expected physician outlet backlash against it. But I think the biggest things about it were, one, is it wasn't binding. It was just guidelines, and they were actually pretty reasonable. The kind of things where if a bunch of reasonable physicians and patients and advocates sat around the table, put it together, it was pretty similar to what to about as optimal as a lot of people would agree with. And more than anything else, it's just one more thing to one more hour in the quiver for, look, these are the guidelines that are helping me. It helps me prescribe better. It doesn't force my hand at all. And hopefully we can see more things like that, where it's not set in stone, it's not rigid, but it helps us practice better medicine.
Right, and also dentists can communicate with their patients on whether the patient wants an opioid. There's some data in the U.S. that supports that dentists have an over-perception of pain than what their patient actually experiences.
Right, and I would imagine there's plenty of jokes in there about the opposite, basically.
Yes.
But that wraps it up for this section. We're going to have a brief break where you're going to hear a little bit about the JAMA and the JAMA Network's new podcast with CME involved. So stay tuned. We'll be right back.
Thank you.
Thanks for joining us.
Thanks for having me.
Hi, and we're back. I'm taking the place of Katie Suda. I'm Mike Berkowitz, electronic editor for JAMA and the JAMA Network, joining Seth, who took you through part 1 of our broadcast today.
Great. Well, welcome back, Mike.
Thanks,
we missed
Seth.
you.
Yep.
So next paper we're going to talk about from this week's release is Mortality Among Professional American-Style Football Players and Professional American Baseball Players by Nguyen and colleagues.
So this is NFL and MLB players,
Right.
And there's been this ongoing debate, particularly around football players, because of the issues of chronic traumatic encephalopathy and concussions and traumatic brain injury, whether there's an increased risk of all-cause mortality as a result of their occupational exposure, which raises a bunch of issues which we'll probably get into.
Right.
And what does this paper add to that conversation?
Right. So basically, it's really hard, to steal from a recent book I read, when someone gives you a number, ask for a second number. So when you're looking at things like NFL player mortality or NFL player neurodegenerative diseases, et cetera. Sorry, that's a tough word for me. It's what are you comparing them to? What are the rates compared to other populations? And professional athletes are tricky because NFL players are almost certainly doing activities on a regular basis that are potentially harmful, but also
Protective.
Protective. They're also doing a ton of exercise.
Right. They're the physical activity paragons we all aspire to be.
It might be surprising for you to hear, but I probably don't exercise as much as an NFL player.
Right.
And then just what are the comparisons? So what was really interesting in this study is they compared professional football players to professional baseball players because they're probably theoretically in a similar level of physical fitness, but doing it in a different style of sport where Major League Baseball just doesn't have the same amount of contact, especially not head contact, repeated minor to moderate head trauma that NFL players get.
Right. There's also a physical phenotype that's different between the two sports. And then just to put a frame around this, which the authors do, I think there's evidence that NFL players compared to the general public have a lower risk of all-cause mortality, but the question is that a proper comparison? So we at JAMA at the beginning of 2018 in February published a piece from a group of researchers at Penn that compared NFL players to strike players in 2015. So that was thought to be a better comparison. And there was a kind of maybe a signal towards an increased risk of cardiovascular mortality, but there was no statistically significant increase. It was kind of a wash. They were comparable.
Right. And that was a paper if you're looking for it. And we'll post it in the comments below, but it's JAMA 2018 by Venkataramani and colleagues. And what's really interesting is they use the replacement NFL players, the ones who crossed the picket line in the strike in, I want to say, 1985. That the Keanu Reeves movie, The Replacements, was based on, which were straining the edges of my sports knowledge.
Right. There's a different movie called The Replacements about an Irish band, too, right? But that's something different. Okay.
Yeah. And what's interesting there is that basically to me, that paper strikes me more of a dose-response investigation than anything else, like a phase 2 study, basically, where because most of the replacement players were fairly professional. They just played in either the Canadian Football League or the now defunct, I think it was called the U.S. Football League, but just not at the peak National Football League level. So they're still professional football players. They just had less exposure to the NFL. And I don't think, the problem is that it's the NFL per se. It's that it's professional football, or American-style professional football. That could potentially be the problem.
Right. So I would think that would have settled the issue, but now these authors come forward and are comparing them with Major League Baseball, full-on professional athletes to say, is there a difference?
Right. Yeah, and they did some really interesting stuff. It's actually really fascinating to read. They used a database that the NFL set up with NIOSH, I'm going to mess this up, a National
Institute of Occupational Safety and Health.
Yep, the federal government agency that looks at occupational safety. And basically has a database of people who play at least 1 year, but I think they need to have 5 years of pension-eligible play. They then got Major League Baseball professional player data from the same time period and restricted it to MLB players who had played 5 seasons. Got pretty comparable stuff. Looked at things like age, which I think the football players were a couple years younger, which based on what little I know, is I think baseball players tend to spend a couple years in the minor league before they play professionally in the show. I clearly learned all of this from movies, but and then looked at other things, like race, other comorbidities, et cetera, and found that of the 3,400 NFL players versus 2,700 MLB players, the NFL players had higher rates of all-cause mortality and higher rates of cardiovascular disease mortality and higher rates of neurodegenerative diseases.
So this is the kind of smoking gun. Maybe that's not the metaphor that kind of people have been looking for in terms of this particular sport and harm to players, right? If you believe it.
Right. Yeah, and it's hard to know. Again, these are very specific populations of, is this saying more about who plays in the NFL versus who plays Major League Baseball? Because there's clearly some differences. There were some race-based differences. There's probably some, or theoretically some lifestyle differences that they couldn't capture in their data. If you just have to watch news or late night television to see what professional athletes are up to sometimes.
Right. So I have kind of a methods and then a broader policy question. The methods question is, this database went from 1979 to 2013. There is a sea change in medical practice over that period of time. And I wasn't quite sure if they if they controlled for, adjusted for, accounted for a kind of a time effect. They did look at the age of the players and looked at them kind of by birth decade, but I didn't completely get my arms around whether that was an adequate adjustment for this fact that recognition is improving, consciousness is improving about these issues, and and care is improving over this period of about 20, 25 years.
Yeah, I mean, to that point, when I talk to patients and their families about potential for concussions, part of my discussion is we used to be much worse at recognizing and treating concussions, and I'm an optimist, even though there's potential bad stuff, we're now better at it and better at catching them and treating them.
Right.
So there's definitely been a sea change, even the short time that I've been in medicine. So.
Right. And is there any evidence from these data that some of the mortality was the difference in mortality, looking worse for the NFL, was driven by earlier year or earlier decade deaths rather than later decade? That's pure speculation on my part, but I'm wondering what you think about that.
Yeah, I mean that's certainly a possibility. And again, even with these few thousand participants they have in these studies, that data, that's still not a huge amount of data. And you have and these are fairly young, healthy people, so the event rates are pretty low. There's not a lot of football players who die of heart attacks. Even ex-football players or ex-professional athletes, it's usually news. It happens at a low enough rate. I'm also curious if these basically, if both cohorts are just young enough that enough of them haven't necessarily died to it's if you have 20-year-olds in 1979, that's what, 60 something now. Is that old enough to die? There was a paper a couple of years ago that looked at physician mortality by specialty, and emergency docs had the lowest mortality by like 15 years or something like that. And then you look at the numbers, and there were 300 to 400 deaths in each of the other specialties. And emergency medicine's a relatively young specialty, only had like 6 deaths in the comparison. So the people who died were people who died exceptionally young, and most of the older docs were just 65 and hadn't died yet.
Right. And I don't know if you read the news this weekend. Anecdote is not evidence, but Bart Starr, the star QB for Green Bay Packers in their heyday, just passed over the weekend, and I think he was 85. And I didn't look at the coverage that deeply, but there was no reason to think it was unusual causes, although that's not always reported in obituaries. On a broader policy scale, now this isn't going to affect your clinical practice. I think very few of us are caring for ex-NFL or Major League Baseball players. We don't know. I guess I don't screen for that in my patient experiences. But there's, I guess, a policy question about whether, if this sport is harmful, whether we want to be paying in as a society the amount that we're paying in and supporting it in the way that we're supporting, or whether there should be guidelines or guide rails around the kind of play that would be less threatening to the health of players, and whether that's important to us as a civilization, as an American society or not. And of course, I don't have those answers, and we would be interested in your opinions if you want to leave comments in the comment field on Twitter, Facebook, or YouTube. Just interested in what you think. We are not especially equipped as physicians to answer that. We as a society need to address that.
Right. And I think one of the things that's important to think about here is it's not just about the few dozen or few hundred professional athletes who play each year. It's also all the aspiring athletes, all the college kids, all the high school kids, all the even the 12-year-olds who have no plans on ever being a professional athlete, but see the modeling from the people who are on TV, on the news, can be idolized, et cetera. And this stuff shakes out. I mean, my wife has long held that no child of ours would ever play football.
Is that right?
Even on an amateur or scholastic level. Fortunately, my daughter has both my build and my athletic prowess, so that won't be an issue.
If I see her, I'm going to throw a helmet onto her and ask her to run 100 yards.
Right. She's good with helmets, though. She recognizes the importance of good helmet safety.
I meant a football helmet, not a bicycle helmet. But okay.
Helmet safety is good. We can't, it's important stuff.
Okay, so interesting study, and the JAMA Network has been in this space, so undoubtedly we'll get some interesting comments.
Right. And one of the other things that's so fascinating to me about it is there's so many different potentials for causality in different directions here. I mean, it's who gets into professional sports. What do you do when you're in professional sports? How much do you work out? How much? What risks that expose you to? But also that makes you generally pretty affluent, and get much better access to healthcare than a lot of people have. So there's so many questions here. It's fascinating stuff. No solid answers, of course, because this one paper did not solve all the problems yet.
But we'll keep an eye on it, and we're moving towards greater consciousness, and I suspect the league will come under some pressures, public-wise and probably not legislative, to kind of make sure that their players are cared for in a reasonable way and playing in a safer way.
Yep, absolutely. So moving on, run through some of the table of contents from this past week's release. A couple of papers. This is another interesting run with all sorts of questions about causal arrows. Association between life purpose and mortality among U.S. adults older than 50 years.
So I'm not familiar with this, but I'm going to say greater life purpose, however it's measured, is associated with lower mortality.
That is correct.
Okay.
Surprise, surprise. They did, according to their methods, they used the U.S. Health and Retirement Study, which included a modified version of the Riff and Keys scale, which is a little more than it's not just like a visual analog scale of how much life purpose do you have. It's like, I don't know, the full scale is 42 questions, et cetera, et cetera. They do lots of things to try to figure it out. And not surprisingly, people who have a greater sense of life purpose tend to be healthier. They did a couple things that were, I'd say, at least have some face validity to check for reverse causality, like a couple sensitivity analysis about people who died in the first year of the study, et cetera. That, again, it's I'm not completely rolling my eyes at this, and I imagine some of it has to do with, some confounding, like people who are healthier probably just have a general better sense of well-being, or people with more life purpose might take better care of themselves because they feel like their life has purpose, so they should eat more and exercise more and smoke less, etc.
Are suicides in here at all, or they don't call that out?
I don't really know.
Okay.
Yeah.
Very good.
But interesting stuff. Again, not answering a complex question in one paper. Next up, another complex issue, management of chronic pain in adults with sickle cell disease during the opioid epidemic. This is an interesting qualitative study. And basically,
I like those a lot.
Yeah,
they're done well.
Yeah, I find them fascinating. I've been involved in a couple qualitative studies. I'm far from an expert, but can be really interesting, especially in complex issues like this. But again, patients with sickle cell have this terrible problem where they're basically have this physiological problem that causes terrible pain all the time, and then have to interact with this broken healthcare system that is prescribing opioids and doesn't have a lot of alternatives. So they did a bunch of interviews, talked to a bunch of people with sickle cell disease, basically found that, no surprises, there's a ton of barriers to getting appropriate analgesia. They were frustrated because their physicians focus a lot more on the dosage of their medication than things like multimodal approaches. There's barriers to getting multimodal analgesia. And that, not surprisingly, patients do a lot of self-medication, and the rates of marijuana use were not surprisingly not low.
Not surprisingly not low, right. Yeah, and the classic image of this is an ED doc. I don't know how it happens at Northwestern, somewhat distrusting these patients because they have pain crises and they have high needs for analgesia, and docs are under the gun to not be as profligate in terms of prescribing opioids.
Yeah, and it's really tricky. There's a great line that I'm stealing from my vague memory of Up to Date from when I was an intern, that even in the best case scenario, when we want to provide appropriate analgesia, our system is terribly apt at doing it. So basically all patients with chronic pain end up exhibiting drug-seeking behaviors because they have pain and they seek drugs to fix that pain, which is not at all inappropriate. And then you run into the, again, multiple complex layered problem of pretty much the only tool we have is incredibly addictive, and then we get frustrated because the patients are addicted to the thing that we gave them, and we don't have great answers, and it sucks.
Right.
Yeah.
Okay.
But yeah, again, qual research can be very interesting. So next up, risk factors associated with atrial ventricular block. It was a population-based study out of Finland in the Mini Finland Health Survey, which comes from full Finland, not a smaller version of Finland.
There are different kinds of AV block. So is this all kinds? Type 1,
yeah,
2A, 2B, and 3?
I think it's for the kinds that we care about, like the kinds that...
Not Wenky block.
Basically the advanced AV block.
Yeah.
And basically found that the traditional markers of cardiovascular risk for things like ischemic heart disease and ACS, so elevated blood pressure and elevated glucose, were the biggest things that shook out of their model, and accounted for more than half of the atrioventricular block, and most of the effect persisted even when they corrected for ischemic heart disease. So it's
even they adjusted that out and it still existed.
Yeah. So it's not just you have a small heart attack, it blocks out, knocks out part of your AV system or whatever, and then you end up with a block. It's things that are bad for your heart in some ways are also bad for your heart in other ways.
But forgive me for diving deep. What's the ischemic heart disease variable? Is it a history of or EKG changes of? Because you could still have atherosclerotic process without that diagnosis in your chart.
Okay. Right. Yeah,
You're on board.
Of course.
Thank
yeah.
you very much.
But this stuff's
Okay.
tricky, but it's also, it's Scandinavia. We've got great databases on this stuff, and
Yeah.
it's not just a 85% of something somewhere.
Okay.
Next up, this one's really interesting. So the Association of Data Integration Tech with Intensive Care Clinician Performance, they did a systematic review meta-analysis of a couple dozen studies that looked at things that integrated clinical data and presented it in coherent ways. So some of it was pretty low-grade stuff, like just kind of what we now think of as fairly simple monitoring systems. Some of them were more complicated things and more tech-heavy things. The way that data is graphed over time, things like when you go, when you go into different panels of your EHR and it shows the data points of, say your vital signs over time, or your labs results over time, et cetera. Some other novel or more innovative things where, graphs of, I don't know what you call them, like sunburst with like the values around a radius.
So what you're describing is kind of data display.
Yeah. Yep.
So is that what this is about?
Yeah, that's what it's about. And
Okay.
basically it found that of the couple dozen studies, there was primarily an improvement in the cognitive workload the physicians had, but not much improvement in other stuff they could measure, such as physicians' frustration with the technology, the demand domains of cognitive improvement and things like that, or cognitive load. So bottom line is better presentation of data is good, but it's current approaches of integrating data are far from optimal.
Right. I mean, it's been a while, but the last time I was with Epic,
Mhm.
I would get these graphs that would show cholesterol levels or LDL levels,
Mhm.
and they were simple up, down based on
Mhm.
each measure. And it was like a full screen, it was full color, but it didn't tell me much more than seeing
Right.
4 numbers.
Yep.
Right.
And that's
So it wasn't that useful. And
Right.
I would hope that things have advanced since then.
right. Yep. And there's some cool pictures and there's some cool examples in the paper
Oh, good.
that they showed.
So
you can
check
take
it
a
out.
look.
Yeah.
Yeah. And again, I think my biggest frustration with EHRs is how much unrealized potential there is.
Mhm.
And I think that's what you're speaking to. Last two we have, I'm going to talk about together very briefly because they're way over my head. But one was a look at the BRCA1 and BRCA2 genetic testing, where they did a quality improvement cost effectiveness analysis to see how to optimally test for the BRCA genes in patients with breast cancer, and basically trying to figure out what's a good pathway. This is part of the mainstream cancer genetics study, basically trying to figure out who should be tested for these and not just do a shotgun approach or
Got it.
individualizing for patients, et cetera, and found that there was some room for improvement. The next one up is development and validation of an esophageal cancer detection model using microRNA profiling.
That's a bit different.
Which is a bit different,
Yeah.
but it's just, for me, doing these kind of somewhat advanced genetic testing, novel things with DNA that are, again, mostly unrealized tests, but this is kind of how we get from the kind of bench research to implementation of this kind of stuff. So.
Right. So do you know these papers well enough to say what they're recommending? No. Okay. Because there is this model where you wait till a proband develops the cancer, then you test the cancer for the mutation. And if the proband has the mutation, then you extend the testing to first-degree family members. I think that's the colorectal cancer kind of model. But BRCA is going in a different direction, which is that people want to be tested preventively, knowing that somebody had breast cancer, but without having necessarily demonstrated the mutation. So I'm interested in kind of what that shows, and maybe I should have read it in detail for discussion. But why don't you guys check it out, and we can talk about it next week.
And fortunately for you, it's free online at JAMANetworkOpen.com.
Yes.
And it's interesting. And basically, according to their economic analysis, they were aiming for like a 10% positive rate. So the different ways you can go through your algorithm to try to do that is really interesting. Instead of just, I heard that such famous person had this test or this procedure done, and therefore I want this test too, or I'm worried about all my patients, so I'm going to test everybody, or something like that.
Right.
So there are ways we can be smarter with technology and use DNA and RNA for fancy stuff.
Yeah, and the microRNA, I mean, we're all into genetic markers. We, meaning we as medical professionals in the research enterprise in the U.S. and internationally, are moving towards precision medicine, where people are being identified, diagnosed, and treated based on mutations rather than phenotypes, which is what we call lung cancer or liver cancer, pancreatic cancer.
Right.
So it's kind of exciting, and there's a lot of churn.
Right, absolutely. So fun stuff. So of course you can read these and more for free at JNOopen.com. Next release will come out Friday. Join us next week again, Monday, our regular time at 2 p.m. Central Time. And of course, follow us on the usual social media channels, Twitter, Facebook, LinkedIn, Pinterest at JAMA Network Open.
And you can hear an audio version of this broadcast on our new podcast, along with Editor-in-Chief Fred Rivera and Deputy Editor Steve Finn's audio summary. That is on Stitcher, Google Play, Apple Music, and anywhere you get your MP3 podcasts.
iTunes, not Apple Music.
Yeah, okay. It can be iTunes too. And check out our translations into simplified Chinese and Spanish, if that's the language you're more comfortable with, of our titles and key points. And always visit us on JAMANetworkOpen.com. Sign up for our emails, and I think that's it.
Yeah, I think you covered it all.
Okay.
All right. Great. Thank you.
See you next week. Take care. Thanks.